Yeah. All right, we'll go ahead and get started. I encourage you to move to the front if you'd like. It just will be easier probably to hear each other's comments and let the latecomers have a place to sit. I have the privilege and honor of introducing our speaker. Michelle Wilson is the lead nurse practitioner for the pre-op surgery at Akron Children's Hospital, where she has practiced since May of 2001. She is dually certified pediatric nurse practitioner with 18 years of clinical experience, originally practicing in cardiothoracic surgery and intensive care, but most recently in pre-op surgery. She authored a pilot project for the Pre-Surgery Preparation Center, which was implemented in May of 2015 at Akron Children's Hospital in conjunction with the opening of their outpatient surgery center, which she will discuss today. She is currently in the DNP program at Kent State University with a focus in health policy. She was the recipient of a 2012 NEWE Scholarship, 2013 AANP State Award for Excellence in Advocacy, 2013 Child Advocate of the Year from Ohio NAPNAP. It was a good year, yeah, and the 2013 Northeast Ohio Nursing Initiative Partner in Nursing Award. She is active in health policy, as you can tell, at the state and national level, serving on Ohio's NAPNAP Health Policy Committee and NAPNAP's Health Policy Committee. So please welcome Michelle.
Thank you, everyone. As you can tell, I have many, fires in the oven or irons in the fire, or however that saying goes. One of my loves is health policy, but primarily my clinical role is where obviously I spend much of my time. And so this project is a kind of a backstory to how it happened. But I think it's important to share because of the relationships that I've built in doing this project. It was a Friday and I was working up in pre-op, and it was busy, really. All heck was breaking loose. So our PA went off and it said, well, the owner of a blue Nissan Versa license plate number. And I'm like, guys, that's my car. So what happened was I went, because they called me to my vehicle, and another vehicle had actually rolled onto mine. So our vehicles were parked like this, and this car with the vibration, I guess he obviously didn't set his parking brake, rolled into my vehicle. So security was there and said, the gentleman's whose car this is, and it was, kind of one of those like old Honda Accord, the interior was beat up, and I'm thinking, oh great, do they have insurance, So he said, well, I'm going to go on my break, but the man is coming. I go, what do you mean you're going on your break? I have an issue here. There's a car on top of mine. And he said, don't worry, it'll be fine. Sure enough, who comes around the corner but our chief financial officer? And it was his vehicle. He was so apologetic. He took me into his office. We exchanged, information, because obviously I had to make, a claim. But I forged a relationship with him that day because I was just calm and accepting and, what are you going to do, right? Things happen. Little did I know how much that was going to impact this project actually going live. Because about 6 months later, I was standing in line at the soup kitchen. I call it the soup kitchen. It's the part of the kitchen where they make soup in the hospital. And he's standing behind me. And he goes, you're thinking about something. I go, well, I have this idea. I tried to float it to my director and the medical director, and I'm not really getting a lot of traction. And so I'm just trying to think like how, and he's like, well, send it to me. I want to look at it. I go, well, it's a clinical project. He said, send it to me. And I said, okay. Like 30 minutes later, I had like a meeting set up for a presentation of the project. And I think, whether it was his guilt, whether it was fate, whatever it was, that's how actually this occurred. And so I wanted to share this project with you guys. I don't have like super fancy metrics. I have just some basic stuff, because I don't know, many organizations, maybe, you guys are different. We don't have like people just walking around collecting data all day. And our EMR is great, but it's hard to get data from sometimes. So I just want to share with you this project that I did. And that proposal, actually I presented to the administration. There was 30 people in the room. That was December of 2012. And so we went live in May of 2015, just to give you an idea of how long it takes to change. And really, the concepts in here are extraordinarily simple. However, change and the management of that change is, I think, what really is highlighted here and has helped me in my health policy arena as well, understanding how to accomplish change. If you do it in the clinical arena, you can do it in any other arena. Sorry. I have no disclosures for this presentation. And the learning objectives are pretty straightforward, actually. Just to describe the concept of the pre-surgery preparation, or the PSP center. My husband calls it the ESPN center, and I tell him it's not the ESPN center, but that's what he knows it as. List the advantages and metrics, how we evaluated the efficacy of the model, and then just describe the challenges to implementation. So the model of care, a little bit more background. Currently, in current state, it's what I'm going to describe. But prior to the opening of the center, all of our patients, simple to complex, came in the morning of surgery. And when I first started, we were bringing them in 2 to 2.5 hours ahead of time, which to a certain degree, morally and ethically, didn't seem right. If someone was having a surgery that was 15 minutes long, like ear tubes, I was having a hard time swallowing that concept. Like, why is this? Why do we? Well, we have to meet Joint Commission mandates. A history and physical has to be done. Okay, so then the wheels start turning. How can we get some of this work done ahead of time, without burdening the families, obviously? Because that was always the biggest thing: is our families don't want to come for 2 visits. And I'll show you how we kind of work around that. So they come in the morning of surgery, they get their child life visit, they get any labs. We're still waiting for the fax from cardiology to clear them. I mean, it's just chaos. And so what we did was from this clinical need of, as volumes started to grow and acuity started to grow, we had to start teasing out the simple patients from the more complex ones. So the complex ones still are done in our main operating room, but the simpler ones, we are now screening, doing all their pre-work, and sending them literally across the street to our outpatient surgery center. So this is how the PSP actually fits into that model. Now, that being said, and they're going to have to find another project manager to do this project, but we need to do the same thing on the main OR and the complex patients. But what we did, think about this, was we flipped the model. When you look at the literature, cardiac surgery, they do like their pre-admission testing workups. Complex spines, all of your like complex plastics, ortho, that is well documented. But this isn't. That's why I told my friend Sarah I need to publish this. Because what we did was all the simple patients are done ahead of time. For us, it was easier to do this change than it was to do the other. And it was going to impact our operations more to do the simple patients first, learn the lessons with the simples that then we can apply to the more complex patients. So think about that. This evolved from our same-day service process, obviously. We timed it because that created a sense of urgency. With change, you have to say, we got to get this done or else. We combined it with the design philosophy of the outpatient surgery center, and by that I mean physically when they built it knowing that there wasn't going to be a nurse practitioner there with a magic fairy wand to make everything happen that morning. So that was a physical limitation that we put in place so that all the work still gets done where it needs to, and not the morning of. The surgeons are still fighting that, but we won't go there. Enhanced with the implementation of the EMR. Think about it. The EMR has allowed us to communicate more seamlessly with other departments in the organization. That really helped propel this project as well. And as I said, driven by volume and acuity, plus our surgeons had been asking for this for years, and nobody really kind of took them seriously. But as we've brought on more people, this really took off. So do any of you work in pre-op or, okay. So like you guys totally get the firefighting versus party planning, right? So in firefighting mode, it's exhausting. It's like an adrenaline rush. And, being a former ICU nurse, I didn't mind that. But when we flip the model, now we're in party planning mode. And by that I mean we're really hosting these families. And we welcome them, we anticipate them coming, and it's a lot more fun because we've got time to think ahead. Now, that's a skill set that as an NP we have, but we had to really kind of change that mentality to make this project very successful. But going from firefighting to party planning was probably the best part and the most satisfying part as a staff member. So what are the goals and benefits of the model? We're able to enhance the patient experience and patient safety, and I'll get into some of the screening forms that we developed with the anesthesia. Enhance the overall operational efficiency, because by teasing out the simples and complex, actually, it had an effect on the main OR in the sense that, all these other smaller cases weren't kind of clogging the system there. We can provide quality, cost-effective, coordinated preoperative care now across the spectrum. We are able to enhance the ability to anticipate problems and intervene early in the process, and that is so key, especially when you look at quality-based reimbursement models that are rapidly coming down the pike. We're able to reduce post-op morbidity and mortality and unanticipated admissions. They're not zero, but it's a manageable proposition. So what are the services that we provide? So all the pieces and parts I had to kind of go through in my head. What can we get done ahead of time? What needs to be done the day of? And certainly teenage girls are going to have a urine HCG that morning, but we can preload that order in Epic for them. A focused pre-op consult or history and physical by one of 4 nurse practitioners that staff it. Actually 2 on any given day, but 4 altogether. Their medication reconciliation is all done. We order and interpret labs. I can't tell you how many times we ordered labs and they were still pending, like coags, and the surgeon's like, forget it, I want to go. Well, then what's the point of ordering So we do whatever we can lab-wise to get those done and interpreted and signed off on before the day of surgery. We verify their informed consent. We do not obtain consent, and I want to point out that part of this project my goal was to get everyone's consent done ahead of time. You have to pick your battles. So that was one that I kind of let go, but we wanted those to be in the system. I haven't let go of it completely because there is a way that it can be done, but it's got to be embedded in the EMR. Right now, it has to be a scanned document, and when you're scanning 50 consents a day, it gets old. Pre-op education and instructions by a nurse. Anticipatory guidance from a child life specialist. So they come in and do an assessment of their separation anxiety, their developmental state. We talk about, does this kid need a transition plan? Is this child going to need parental presence for induction? Is this child going to be accompanied by a child life specialist? Are there medications that we need to order or preload in the system for the day of surgery? So all those things are thought about and documented so that the morning of, that team across the street picks it up and runs with it instead of making phone calls about what needs to be done. Assessing and planning for post-op needs as well. So we give parents a lot of their discharge instructions ahead of time so that they know they've got to buy not 50 popsicles, but perhaps 100. It really makes a huge difference when parents are prepared. Initiate consults, referrals, and any follow-up. Ability to accommodate special patient needs, the autistics, some of the kids who just are really going to need some good planning, especially with transitions. And then the goal is to complete the entire visit in 30 to 60 minutes. I will also say that this visit is good for 30 days. So any pre-op history and physical has to be done within a 30-day window prior to surgery. So that's what we tell the parents when they come, that if you get rescheduled, this visit is still good for 30 days. Hopefully they can get rescheduled within that 30-day window. And there's exceptions that we make if they fall outside of it, but sometimes the surgeon will just redo the history and physical to meet that 30-day mandate. So who refers their patients to us? Oh my gosh, this was a really hot topic. I had a lot of people wanting to refer patients. Believe it or not, once the idea was floated, the surgeons really started to latch on. In fact, there was competition. ENT was like first in the office saying, we want first in. Well, they have a lot of, we see primarily a lot of ENT patients. The tonsils, the adenoids, the ear tubes, those kids are usually otherwise healthy and great candidates. But there were some ophthalmology patients that, we thought would qualify. Some GI, some of the scopes, some of the more straightforward scopes. The dental center, we do a lot of patients who are on Medicaid, who Medicaid will reimburse for their extensive dental work with, their severe childhood caries to be done under general anesthesia because it's safer. The plastic surgery center, they have some, their basic nevus removals. Those patients would qualify. We did end up adding the hand surgery center afterwards, but they weren't on the initial docket. And then select private practices within this. There's 2 private ENTs that have OR block time in the outpatient surgery center and do a fair volume of cases, so we included them. So it wasn't just the employeds. We did do some of our private docs as well. So our staffing model is, as I mentioned, 2 nurse practitioners, 1 to 2 nurses, 1 to 2 child life specialists, an MA, and a unit secretary or a scheduler. And believe it or not, this is what works. Now, as you notice, there's no physicians in this center. The physicians are really the surgeons, the anesthesiologists, who are off doing their own work. But we communicate via our EMR. If we have questions, we can call them. And believe it or not, it works really well. So the center flow looks like this. The surgeon will initiate the consult in the EMR. So when they go to schedule the surgery, there's a little checkbox that we purposefully embedded in that order that says if they need a PSP consult, click here. So if they're scheduling in the outpatient surgery center, they certainly need that PSP consult because the day of morning services are not available there. Now the patient, if the patient is in the office with the surgeon can have them walk over. So there's no need to repeat or come back. If the family has another hour, they can walk over and be seen, which is great. If not, if they have something else to go or somebody's got to get to school, they can certainly schedule a future visit they get a televox reminder. So it's an automated call, just like everyone does when you go to the doctor. The patient arrives and then is roomed as soon as possible. And I'll show you, the next slide has our location. The nurse will greet them, do a very brief nursing assessment. Either the MA or the nurse will complete vital signs, which then generates a BMI, and I'll explain a little bit why the BMI is so important. And then they see a 4-minute anesthesia video that answers questions, but I think too generates a few questions as well, so we address those while they're there. We complete their pre-op history and physical and verify that they don't have any questions about their procedure or that, consent has been obtained. Initiate any labs or clearances or anything. So the ability to predict what this kid's going to need to be sail through the process the morning of, that's what our job is. The child life specialist then completes the anticipatory guidance visit. The RN discharges the patient from the center with an after-visit summary. So a lot of our instructions for MPO, just general things, are on that after-visit summary, which is nice because they leave with that in hand. Now, the time of the surgery evolves a little bit, but we give them that 2 days before surgery, and then go over and make sure that they understand their NPO instructions. And then before they leave, we do a brief 5-question survey on an iPad. How was your service? Was there anyone who we can tell, did a great job? Are there any improvements? Very simple, brief. Not even, a minute or so. So location, location, location. So when you start separating out operating rooms, the biggest thing we had to figure out was, where are we going to see these patients ahead of time? We didn't want them getting confused with the same day patients, but then it was too far and we staffed too many areas to have nurse practitioners in a different building. So we kept them in what we call rooms 1 through 5, which are these areas right here. So the main OR is back here. This is our kind of pre-op area for the patients using the main OR. But these 5 are next to our holding room. These are 1, 2, 3, 4 holding rooms. And so it allowed us to be cost neutral in this venture. And that was really important to Mr. Trainer, the CFO. So this way, if this area is slow, we went across the hall and helped out our colleagues in pre-op. And if they are slow, they can float over and help us out a patient or 2 here. If we separated out the units, then you're looking at, again, additional FTE, additional cost. We were able to do this. Is it sustainable long-term? Probably not, but we're just going to be completing our first year, and I'm sure we'll look at everything, but that's how we decided to do it. So how do we decide who are good candidates to come to the outpatient surgery center? We had to develop some screening tools, and these were evidence-based and pulled by our anesthesiologists. So we worked with them because we had to wrap our brains as NPs around, what does that OSC candidate look like? And now we intuitively know what they look like, but the surgeons really had to know what they look like as well. Because unfortunately, initially we thought, well, we can screen them, we can do their BMI, but then if they got to us and they weren't OSC candidates, we had to reroute them all the way back to the surgeon's office, and then put them on the main OR schedule, which when you have a lot of block time in the outpatient surgery center, you have very little block time in the main OR, which meant that the patients were going to have to wait perhaps 60 or 90 days, which was unacceptable. So that's why we are having the surgeons do in the office the BMI, so that the patient gets sent on the path early on in the process. It's not that we didn't want to do it, but I think they were like, well, you have like the thing to, measure them, and guys, it's not going to work. The patient's going to suffer, and we're all just going to be spinning our wheels. So that was a hard sell. So we have a primary and secondary screen. There are also some exclusion criteria. The referring provider completes all of the screening. And then this will guide them as to the eligibility for that patient that they want to do surgery on in the outpatient surgery center. Now, the key was that everybody thought that these were going to be on paper. We put them in Epic because that way we could refer back to them. So Epic had to build that for us, which was very interesting. It has to be done prior to scheduling the OSC case and the PSP visit. And what we're really looking for and trying to pull out are our ASA 1s and 2s. So I know this is very small, but just to give you an idea of what we came up with, these top 7 questions are the ones that, this is from the primary screening form. So has the patient ever been hospitalized for more than 1 day? That will pick up some complex patients. Has the patient ever required unplanned hospitalization after surgery or procedure requiring anesthesia or sedation? Has the patient or immediate family member had a reaction to or complication from anesthesia other than nausea, vomiting, or slow to wake? So we're trying to pick out the kids with MH. Does the patient have any medical conditions requiring ongoing care with a healthcare provider? That will pick up some complex patients. Has the patient had a respiratory illness within the last 2 weeks? In Northeast Ohio, pretty much everyone does all year round. So that one we're still working on, but you get the gist. Any brother or sister suffers SIDS. And this is really just specific to infants. One of the exclusion criteria is nobody under 6 months of age or post-conceptual age of, I think they have to be 60 weeks or older. Is the BMI percent for age greater than 95%? So anyone who has obesity, which is pretty rampant everywhere, really isn't a great candidate for the outpatient surgery center, and I'll go over that a little bit. So you can see we kind of have, like, if there are all no's, they pass. If there are a couple yeses, there's some options. And so we do have nurses as backup, like for pre-screening. So the office could call a pre-screener if they had a question. They could certainly call one of us. But then they could also opt to do a secondary screen. So the secondary screening form is obviously a little bit more detailed, and I won't read all of these, but it pretty much goes by, there's the post-conceptual age criteria. We don't want to be doing premature infants who have apnea in an outpatient surgery center. Syndromes, there's another kind of exclusion criteria, like some of the kids who have Pierre Robin, anybody who's got a major airway issue, not laryngomalacia unless it's severe laryngomalacia. But the surgeons, though, argued with us. They're like, well, if the kid has a trach event, why can't they come to the outpatient surgery center? They have an airway, And we're like, but they're not ASA 1s and 2s. Like, we got to kind of rein that back in. Heart issues, especially unrepaired congenital heart issues, breathing or lung problems, muscle issues because of the weakness, neurological disorders. This one too, this is a NP call. We have to evaluate it. If seizures are out of control, they're probably not a good candidate. But if they have well-controlled, seizures and they're following regularly, we've sent them over. Kidney, blood, endocrine, and you go down, and then severe obesity. So that's one of the biggest exclusion criteria that we have, is that the BMI, if it's greater than 99% for their age. And in our EMR, it pulls up, if you document a height and weight, it will document not only the BMI, but what the BMI percent for age is. So under 95, you're good. 95 to 99, we have to talk about that. But anyone over 99th percentile, that's one of the exclusion criterias. And I didn't realize this until I was looking at my slides today, but this is not the exclusion criteria. But I will give you, I'll reload it onto the speaker website. But really, it's infants less than 6 months of age or less than 60 months, or the post-conceptual age issue. Obstructive sleep apnea documented by polysomnography. If they have a sleep study that says they have sleep apnea, don't matter, they're not going. Malignant hypertension, yes. I'm sorry? AHI meaning? No, we don't use that. That's actually probably a better indicator. We just use the post-conceptual age less than 60 weeks right now.
For the sleep study, the apnea index?
Oh, I'm sorry, I got confused. No, if it says any mild, moderate, anything on the sleep study, they're not a candidate right now. We could use that. That would actually probably be better. Did you have a question in the back? No? Okay. There's other things that we had to develop, and some of them were relating to respiratory guidelines. So an uncomplicated URI may have surgery in the OSC 4 weeks after symptom onset. A complicated URI, and it goes through fever, everything else, 6 weeks after symptom onset. And then lower respiratory tract infections, 6 weeks. So, a lot of the ENT patients are constantly sick, and that's why they need surgery. But we developed some loose guidelines. These aren't strict, but to give clinicians some idea of what, again, those patients look like. And then we went over some of the other exclusion criteria. I'm sorry? Asthma is not, in fact, probably half the patients we send there have asthma. As long as they are, well controlled, not having an active exacerbation, if they are anything probably more than mild persistent, they will need clearance from their pulmonologist, because the mild intermittence and mild persistence are not really probably followed by pulm, but anyone more than that probably is. So we will reach out to pulm. Do they need pre-op steroids? Do you want to up their inhalers for a few days? Yes. So that's kind of, again, those kind of NP judgment calls. So if I'm getting a history and I get a sense that there's anything more than mild persistent asthma, then I reach out to their pulmonologist. So in developing these screening forms, we were kind of nervous at first. We wanted to make sure that we caught all of the patients that we needed to. So what we did was we did 143 OSC screening forms, just primary, pre-go live, and we gave them to the surgeons and said, have at it, let's kind of see what you guys can do with this. So as you can tell, almost half of them had no positive answers, meaning that they were OSC candidates. As you start going around the circle, though, this was 1 positive, this was 2 positives, there were 3 positives, and there was 1 or 2 patients who I think had 4 positives on that form. So it gave us kind of an idea of their patient population as well. Afterwards, we did some education and outreach and kind of answered a lot of questions, revised the screening forms appropriately. And then as you can see, they were doing a much better job picking out those ASA 1s and 2s. There really weren't any 4s anymore. And actually, I think I transposed these. This is 0 positive, 1 positive, and 2 positive. No, there weren't even any 3s on there. So we were able to, with modifying the document and doing some communication, we were able to improve the screening process. When we had them try kind of the secondary screens, so post-go live, they had to do, there were 6 initially that got pulled out when I looked at all the other forms. And as you can see, some of them got flagged because they had, I don't know what an unspecified breathing issue is to this day, but that's what was put on the form. It's probably asthma. Prematurity, but now he's 6 years old, so then that really doesn't matter. Negative secondary screen with 1 positive on the primary, and then there were all these other kind of like hospitalized for asthma. So it just gave us an idea of, what was getting flagged on the secondary screen and were there any tweaks that needed to be made there. And I think we've actually left the secondary screen alone. So the BMI, why do we focus so much on the BMI? If it's an elevated BMI, we use that as a screening tool. Obtaining the BMI in the EMR for us is very simple. As I said, it's calculated. When we went to the dental service, they didn't have equipment to do height and weight. So they had to buy scales and measuring, sticks for their walls. They actually go to the CDC website to calculate it because there's only 1 dentist that's actually employed. And the rest of the dentists kind of hit or miss. They're private, so they don't use Epic as much as the employed dentist does. As I said, up to the 95th percentile, we are good to go. If it's between the 95th and 99th, we consult anesthesia. Are there any comorbidities that would add risk? What is their past medical history? Are they having an airway procedure? Because somebody who is borderline, who's having tonsils and adenoids, even though they probably need it, If their BMI is at 99th percentile and they're having, like even a dental procedure, that's a longer case. They give a little bit more narcotic. There's kind of nuances to what anesthesia does with those patients. And also just how, if they've had anesthesia in the past, how have they done? If they're over the 99th percentile, they just go to the main OR and we reroute them. Now, we do collect data, so there's a kind of an Excel spreadsheet, really, that we as NPs will log in those patients because we keep track of that. Again, that's another measure of organizational efficiency, because if the surgeons are doing their screening appropriately, we really shouldn't be rerouting too many people. Just a slide on BMI as it relates to general anesthesia. The higher your BMI, the more potential there is for airway obstruction, perioperative desaturation, especially in the PACU. That's what we worry about. Obstructive sleep apnea and their ventilation, it goes without saying. I mean, the more you obstruct, obviously, the less you ventilate. And again, when you're waking up, that's not what we want to see. Kids who are obese, we have a more difficult time obtaining IV access. And that can be an issue. And even just monitoring, simple getting a blood pressure is a little bit more difficult. Cuff sizes become much more important. With the increasing circumference of their necks, it's more difficult to intubate them at times. Issues with post-op opioids and sedatives, they tend to go a little bit lighter because they don't want them to obstruct and start having issues with ventilation. There's increased risk with comorbidities, somebody who has asthma and undergoes GA. If their BMI is elevated in addition to that, again, it adds more risk. And then just the general impact of pharmacokinetics of general anesthesia when you have more adipose tissue laying around. So that's why the BMI is so important, and we use it as a primary exclusion tool. I would say that's the thing we worry about the most, is just making sure that the kids' BMIs don't exceed that 99th percentile. So again, just kind of reining it back in, pulling in, like, what are the advantages? Obviously, patient satisfaction. We think we've enhanced it, at least from the feedback that we've gotten from our iPad surveys. And they, you have to remember, some of the frequent flyers know the old system. And so they kind of didn't really feel comfortable at first coming back in, but now they understand the value of it. And when they show up the morning of and they're just really fast-tracked, they like that. So that's how we've been able to engage that part of their patient satisfaction. This is cost-effective and coordinated care. We have an enhanced ability to anticipate problems and intervene. We've also improved our on-time OR starts, which again is another measure of organizational and operational efficiency and operative flow. We've reduced our cancellations, which prior to the implementation of the OSC and the PSP was actually almost 10%. They didn't want to share that with me, but you kind of intuitively know that. So 1 out of 10 kids were getting canceled for one reason or another. And now that's being monitored a lot more closely. And then just generally, everyone's more prepared. So we just actually went live with our billing model, let's see, February 10th. This is also something that could have probably been a whole nother project that somebody could have taken on. But for years, I've had surgeons tell me, there's no way you can bill for the pre-op visit. It's part of the global. How many of you have heard that? Okay. Don't listen to them. It is possible. You have to, though, engage your coding and billing team. You have to engage the surgeons because they have to put modifiers on things in order to allow you to bill. And the best way that we have found to do this is turn our services as NPs into a consult service. Now, in discussing that with the surgeons, I've only had one ENT surgeon, and he's our collaborating physician, so we have obviously a relationship there, but he stood up at one meeting and said, because people kept saying, well, why don't you just do the history and physical in the office? Like general surgery, like pediatric surgery, they do a great job. Even at our organization, it is complete, it's head to toe. But ENT, like, it's pretty much here to here and nothing else. Like, what do you, like, was it really worth asking them to get a stethoscope? Like, not really. So what he said was, and once he stood up at this meeting and said this, that's what started to propel this idea. Because I've had this idea for a long time, as I said. I've heard so many people say no to me, and I didn't accept that because I knew that there was a way to do it. I just didn't have the right people, the right tools. So we hired a new coding and billing manager, and I met with her, and I'm like, oh, Rhonda, I'm so happy to meet you. How long have you been here? Oh my gosh, 2 days. All right, so here is our plan. We've got to get a billing model in, and I need your help. And you know what? She helped me. So don't take no for an answer. We turned our services into a consult model, hence that order for a consult is embedded in the EMR, that OR case request. So then that is what generates the work queue so that the nurses know who to schedule, right? So anyone who has that clicked gets to a work queue. Our scheduler schedules them and puts them in the PSP center. Now, we have to communicate back to them because that's a consult model. So we have that communication tool in our EMR. We generate a letter. Our H&P, our plan, everything goes right back to the surgeons, which was another funny story. Dr. Milo, who is the collaborating physician I spoke of, who stood up at the meeting and said, this needs to occur, also said, but I don't want to get a letter back in my inbox. And we were like, well, you can't have your cake and eat it too. You've got to, if you're sending it out, you got to bring it back in. But all we do is CC him at the bottom, and because we have a shared medical record, we're able to not have to send or fax a physical letter. So as long as you have a shared medical record and you CC the referring provider, that meets all of the billing regulations. Again, I practice in Ohio. I can't speak for every state, but this is what we've worked out, and we're live, and we're going, and it's going very well. So that talks or speaks to the work queue, it speaks to the consult order, and then the buy-in from the surgeons. Now, I will say our private docs, we have a couple of private urologists, they are still like fighting the model, and we're like, listen, if you want to do your pre-op history and physical, we're not mandating this service, we're just offering it. You just can't do it and start it the morning of. Everything needs to be worked up ahead of time. So there is an option to send the patient to their primary care provider, and we will accept that, absolutely. We can't, like I said, mandate that this be done, but we just don't want it done the morning of. So what we needed to work on, in summary, we had to work on a lot of things. The anesthesia screening questionnaires and processes, the patient flows in different scenarios, our own processes, staff, equipment, and support, communication and education on all of these processes. I mean, I went and met so many different people. I had to go to every single office. I know every office manager. I know all the office coordinators, and they still call and have questions. All the requirements for the pilot EMR build, there was nothing like this. And I don't know that this perhaps exists anywhere else. And if it does, I'd love to speak to you afterwards. But I learned a lot about the EMR building this because I had the clinical knowledge, and they paired me up with the EMR person who made it work for us. PR materials, we're still working on that, but there is something on there about the PSP Center, our billing model, and then change management. Actually, you can't really see that well. We did have to build a timeline. When you're doing projects, I think having a timeline helps. You have an endpoint, and so then you develop a pull plan that will pull you to that endpoint. So the initial pilot started on October 15th of 2014. And then as you can see, every month we added a service. And as we added services, we built on what the previous service did, right? So the lessons that we learned with the ENT center benefited plastics. The lessons that we learned with ENT and plastics benefited ophthalmology. And so we had to start small, and then we widened our circles from there. We did have our EMR OR software go live right in the middle of the project. But actually, it was a blessing in disguise because that's how we were able to bring on our private practices, because they needed to be able to communicate with us via Epic for that consult order, for getting the case scheduled and things like that. So we were able to engage them through that module. And then the OSC opened on May 5th, Cinco de Mayo. We were all supposed to bring in some sort of like Mexican something that day, but we were so busy that I think we forgot. But anyway, it's hard to see, but there's a timeline that we developed. Some of the, I co-led this project, and my other half was a woman named Trada Gilbert, who used to work in the medical staff services office, but she got into Lean Six Sigma and really is one of our what we call a deployment leader in the Center for Operational Excellence. So I led this project with her. And so she had a bunch of tools that were really helpful. And I don't know if any of you undergone any kind of Lean Six Sigma training? If not, I highly encourage it. It comes from the Toyota model, where they make cars. And how do you make things efficiently, safely, streamline processes, because we're great at creating very cumbersome processes. And so this was really helpful. I'll show you in just a sec, but some of the tools that she gave me were an A3 document, the process of a Kaizen, which is a rapid change that needed to occur, value stream mapping. So what is it that you value and how does that go through the system? A pull plan, as I alluded to, with a timeline. Single patient processing is actually more safe than batching, meaning taking patients and trying to get them all done at the same time. So we use single patient processing. Even if there are 3 patients that show up as walk-ins, we take back 1 patient at a time for safety. Level loading, so when we've got 5 walk-ins and we've got 5 rooms filled, they're given coupons to go and eat lunch and perhaps come back in a half hour so that they're not waiting. And then we start with a purpose, we receive information, we make decisions, and have a master task list. That was kind of the process of how we got through this massive project. And also we had a parking lot that was literally a huge Post-it on the wall that were ideas that were good ideas, but we weren't sure how we were going to do that or get to them, or we needed more information on them. So she taught me about these 5 lean principles. So we want to specify value, and we define value from the standpoint of the final customer. So we're all family-centered, but in a customer-based model, we want to look at things from their eyes, not from the provider eyes. Identify a value stream, so all of the actions required to deliver to the customer, both internally and externally. We want to identify waste and eliminate wasteful steps in the process. And that takes a special set of goggles to find waste. But once you identify waste in your process, it almost becomes like, I can't not see waste, almost. Make the value flow. So rearrange it so that there's hardly any interruptions. So we have a very fluid process in PSP where we have a whiteboard and we communicate when the patient arrives, there's a time, and then each of us puts our names up there, and when we're done, so everyone communicates in a visual manner. We could do it through Epic too, but we like our whiteboard. Let the customer pull value through the process at the rate that they want it. And then, obviously this kind of search for perfection. So this A3 document has many different components to it, and it's actually on like an 11 by 17 piece of paper. It is designed to be awkward so that it sticks out and we have it on a wall. But essentially, you're defining the project, kind of, going through metrics. How did you, what are the goals? Everything is on there so that at one glance, we could look at it and refer to it so that we kept our focus in that direction. And then what is a Kaizen? The summer before we went live, I hosted with Trada a 2-day Kaizen event. It was really about a day and a half. In a Kaizen, we pulled in, a normal Kaizen is about 8 to 10 people. We had so many stakeholders. There were 75 people there, anxious, waiting. I mean, like housekeeping, like everyone wanted to know what we were doing and how they could help. And so that's how we got a lot done in a very short amount of time. So the second Kaizen was really just tweaking what we all did in the first day. So then from the Kaizen, we developed, again, kind of another document that had everyone, all the stakeholders, what was in scope, what was out of scope. Our Mahoning Valley Surgery Center was out of scope. We weren't going to touch that part of the operations. It's important to know what you're working on and what you're not, and all the goals that we had set forth, the background, the current criteria, all of that, and where this was all going to take place. So these documents were very helpful, and she helped me generate them. Again, this is just the second page where for the Kaizen, we had divvied up into teams and who was working on what and what decisions those teams made. Again, in order to get any kind of change done rapidly, that's what had to happen. For the proposed metrics, oh my God, we had so many things we wanted to measure, but ultimately we had to make a choice as to what we could physically measure. But those were some of the things that we were able to at least come up with and have ideas for. I don't know how many of you know about change theory. There's a lot of change theories out there, but John Cotter is probably one of my favorite. And you can see that, and even just me presenting today, you can see how we created kind of a climate for change. We knew that something had to give. Enabling the whole organization, it's so important. When you have a great idea, that's great, you know it, but how do you sell that concept to the people who really have to help? You can't do it by yourself. And then implementing and sustaining the change. So that's where we're at when we're going to complete 1 year of our PSP Center opening. Already we've had what we call violations that we've had to call people on the carpet for, and that's part of sustaining that change. A lot of times, like, we were catching some of the ENTs one shall remain nameless, but he was really, you could tell he just wasn't paying attention to the BMI. So I said to our clinical coordinator, I said, okay, call the office, and you're going to tell them that the BMI is too high and the patient needs to be rerouted. Because normally we would just take care of it ourselves. Once we put that work back on them, oh boy, you want to see the change happen? It happened, right? So that's, kind of giving them that feedback gently, professionally, but saying, guys, if you're not going to do the work, you can't reap the benefit of our center. I must keep pushing this there. And then addressing the people side of change. So, there's always a project management timeline, so there's an ending, the exploration, and new beginnings with a goal, but we did kind of see our morale tank. I mean, when you start looking at the Kaizen documents and the A3, you're like, oh my God, we're never going to do this. So managing to kind of keep people's morale up during a lot of change was also very important. We met separately as NPs every month to talk about it, just talk about our feelings, and to give us a forum to be able to say, are we doing okay? Are we not? What are the things we're worried about? Patient safety was huge because we didn't know what we didn't know sometimes. And then our child life colleagues, kudos to them. They kind of didn't come on until, I don't know, a week before we opened. They were one of the late adopters, and they just kept saying that they just didn't understand why. Now they are the biggest sellers of the concept. But what they did was they too had limited resources. So how did they look at things? They looked at the evidence, and it showed that from 7 months to 7 years was kind of those ages were at the highest risk for emotional trauma due to medical experiences. So that's really the age group that they focus on. That's not to say that they don't see the older kids. It might just be a more kind of limited visit. But they address emotional status, and they kind of stratified that. And then obviously they look at family support. A family who's high functioning, who can support the child, might need less attention than a child who is medically more fragile and the parents have less resources. So they also collected data, and they wanted to see what they were seeing in their PSP patients. So level ones, which are pretty much the dominant category, the families the families were supportive, the children were in minimal distress, and the children had some familiarity with medical processes in general. But as you can see, level twos and level threes, which level threes was maybe 1 or 2 patients, those kids still get services, but they get a more extensive plan for the transition on the other side. That might be, the autistics or some of the kids with high anxiety. So what were the implementation challenges? Oh my God. They were a lot, but obtaining buy-in by far was the biggest challenge. Selling that concept to everyone that I knew. Multiple meetings throughout the course of that time to get people on board and to help them understand the concept that we were trying to implement. I will say the EMR build was complex, and I'm not a big computer person. I mean, I do fairly well, but I've learned a lot from it and became a super user. Project charter and then the funding kind of really staying cost neutral was really hard. But I promised Mr. Trainer that I wouldn't increase costs and that I would be able to bill for these services, and I kept those 2 promises to that gentleman, even though he smashed my car. The surgical subspecialty office flow before the patients arrive, like everyone does things differently. Like the ENT center does things different in their office than the GI folks, than the dentals, it's just crazy. So wrapping my head around those processes, because I'm thinking like this is really straightforward, and they're like, but you don't understand. Our GI patients actually have to think about whether they want to have a scope. I'm like, oh my God. Well, okay, we didn't know that. Like, okay, so how can we, make the process look better for you guys? So we had to customize it, keeping true to the principles, but we had to customize plans for different services. And then the billing model, like I said, we just went live in February, so that took a long time to get buy-in, and there were many obstacles to trying to get that live, but it's there and it's working. More challenges and concerns like, how do you avoid multiple trips to the hospital? Sometimes they're walking in while they're seeing another service. That's fine too. We can be accommodating and flexible. People were concerned about increased travel time to and from. And I'll speak to our national and international patients in just a sec. Increased time off work for parents, increased cost to the parents. It was labor intensive for the staff. The surgeon still has to update the H&P, and we've given them that kind of mandated joint commission statement so that they can apply that. And then wayfinding, because when I showed you the diagram of where we are, we're embedded in pre-op, and so it's hard to find us. I had an idea for an app. That's still out there. I would love to have a little app that would kind of direct our patients like a GPS. But in the meantime, we developed like this little golden ticket. So it's literally on like golden paper. And if they got lost in the hospital, all they had to do is show this, and somebody could actually get them to us, and it did work. We still do use it, probably not as often, but I'm still going to pursue my app idea. Special considerations, so we do have that walk-in option from the surgeon's office the day of. The PCP or the surgeon has the option of completing that history and physical, so we don't want to leave out our primary care folks at all. Those community pediatricians or our own primary care providers are capable of billing for that, so we don't want to take that away from them as well. Plus, we have plenty of patients to see. Patients who live more than an hour away have the option, we've agreed, to walk in the morning of surgery to the PSP, but then they have to walk over to the OSC. It's not ideal, but it's a compromise, and if we ever move over there, I think it'll work a little bit cleaner. They do get a pre-screening phone call by the RN because we don't want any surprises. So somebody eyeballs that chart, calls the family, does a little pre-screening, and make sure that they are good candidates before they walk in that morning. Now, the national and international patients that we see, Dr. Hurdle is one of our ophthalmologists or ophthalmology surgeons, and he has a wide variety of patients from all over because of his nystagmus procedure. So we do a pre-screening phone call. It is crazy. Like, you should see all of us getting out our phones trying to figure out what time it is in China right now. Can we call them? It gets nuts. And then what we do is try and get the PCP's records to be faxed or emailed or sent so that we have something to look at, something to give us a heads up and reassure us that there's nothing else that we need before that patient steps in on our property. So in our metrics, what we did was we, point at myself. We collected data for the first 6 months of the pilot. So we saw 710 patients, which was an average of 7 patients per day. 82% of those were scheduled. 18% were walk-ins. The average visit time was 45 minutes. Now, of the schedules, there was a no-show rate of 6.3%, which actually is not too bad. And then our average walk-ins per day were 2.3 patients. So we weren't seeing a lot of walk-ins initially, but that's changing. So who were our early adopters of the change? Here's ENT, right? They love it. And their patient population fits it. And it's a high volume, low acuity, high dollar generating service. So that's who primarily uses it. Ophthalmology does too. GI, and I mean, there's one patient in plastics. I mean, plastics doesn't use it that much, but I think that they will, given some more time. So ENT loves the walk-in service. In fact, the first day we went live, one of the ENT surgeons sent us 7 patients on go live day 1. We're like, thank you. And we got them all seen and tucked away and done. So, you know, there's GI, ophthalmology, and then plastics. Actually, plastics uses the walk-in more than the scheduled. So what is it? Who's doing the H&Ps really? Who's evaluating the patients in post-implementation? So as you can see, again, the NPs in PSP are seeing about 92% of the patients. The surgeon does, 5%, and then the PCP is doing 5%. So you can see that most of the patients we're seeing. But again, we're not excluding the other 2. So ongoing, what we're doing is our implementation metrics are monitored by the PSP committee. So every month we look at these and we try to make improvements. So in this time period from May, so this was post go live, to December, we saw 3,175 patients, so it goes about to 20 patients per day on a 5-day-a-week schedule. Our walk-ins have increased a little from 2.3 to 3.5 patients per day. Our no-show rate is 8.9, but I found out that that includes reschedules and cancellations. So what we're going to do is separate those out so that we know kind of categorically what that looks like. And only 4 PSP patients have had their surgery canceled the day of. So that's pretty remarkable. Some more post-implementation metrics. Our on-time OR first case starts are 92.6% in the outpatient surgery center, which is great. The cancellation rate, before PSP, we had gotten it down to about 4.85, but right now in the outpatient surgery center, it's 2.5%, which is pretty good. The BMI reroute rate, as I discussed, we're following that, and that's 2.4%. So that's not too bad. We want to see it around 1 to 2. We've had, in this time period, the May to December of 2015, we've had 9 post-op admissions. One was a dental patient who really had a lot of narcotic on board and actually coded in the PACU and had to be admitted to the PICU. But that's the only one so far that had to go to the PICU. So again, speaking to that reduced morbidity and mortality. And then our patient satisfaction scores on average are 95%. The one thing we did do is look at, in general, why are patients being canceled, because we found out that like the first 2 months of go live, 40% of our cancellations were NPO violations. So we changed the NPO rules and then, of course, didn't communicate those out. So it was our fault that the medical director for the outpatient surgery center made their NPO solids midnight, which we don't do that on the other side. We do allow them to have a light breakfast. And so we didn't communicate that out. Hence, many patients got canceled the first 2 months, but we've corrected that. But in general, if you look at, here's our sick patients, they're probably, the most reasons why we cancel. Some were because they weren't OSC candidates. This too bothers me. Just, dealing with our patient population and social issues. How can we reach out to those families who perhaps don't have resources or phones or ways to communicate with us? The teenagers and their experimentation. And then other were like things like, I didn't even know, like their condition got better and so the surgery was canceled, we do have like a template for our huddle. So we talk about all of these things every day and look back yesterday and see what did happen, what could we improve. Here's a picture of me with Trada. And this is really outside of the outpatient surgery center. So the building is absolutely beautiful. Kudos to my staff. I couldn't have done it without my nurse practitioner colleagues and Tara and Janice, who are our nurses in the PSP center. And of course, my family, last but not least, my husband and my 2 kids. Do you have questions? Yes.